It is my pleasure to introduce Dr. Mahmoud Khalifa, who is my mentor, direct mentor also. He actually came here and joined the department as a professor back at the end of 2014, only about half a year before I arrived. Yep. There are many actually stories, but we don't have time to share them, that happened, since then. So I would like to say a few words about Dr. Khalifa's history with us. He actually obtained his medical degree from Cairo in Egypt, and then he subsequently received his master's degree and a PhD in pathology. And then he continued his training in pathology at the University of Oklahoma, George Washington University, and also Georgetown. And he also joined the Armed Forces Institute of Pathology in Washington, D.C. for a while. He held several laboratory medicine leadership positions in quite a few North American universities. It's not a place to actually list everything. Of course, he's certified from ABP, but not only that, because he joined us coming from Canada. He's also certified for practice in Canada from the Royal College of Physicians and Surgeons over there. So Dr. Khalifa's professional career focuses on gynecologic, GYN tract. But I had a chance to work over the years also on quite a few cases with him in breast and other things, especially in the beginning, because he actually introduced the subspecialties here. Before then, the department, it was my understanding, it was actually a general sign-out practice. So Dr. Khalifa actually made significant changes to our department. And then over the years, he had the chance to improve the department tremendously. There are many things that actually I can say. It's just that I don't have enough time to do it. So please welcome Dr. Khalifa. Thank you.
Thank you, Emil, for the discussion. Always when they give you the first talk after lunch break, you are in trouble, because now my job is to keep you awake. Now you're ready for your nap and your head is saying, oh, let me sleep a little bit. So let me see how can I go through this lecture and try to keep you awake. How bad can it get in gynecologic pathology? Like really? So the theme today, obviously you noticed, it's errors and patient safety, and this is a very complex topic. But from my personal experience, I think I am part of that problem. My own thinking is part of the problem. How I take myself seriously and my ego, and how difficult it is for me to admit my imperfections and that I am wrong. Sometimes I need help and sometimes I'm going to be wrong. So hopefully I can get this across to you today about how easy to be wrong and how people are really taking themselves very seriously. I think the message, if you get anything from me today, is to take yourself a little less serious. So I'm going to present you an inventory of cases that I gathered over the years. I gathered them from galaxies far, far away. So none of them involves anyone in Minnesota. So you can relax and don't feel paranoid. Don't take yourself seriously. I'm not going to get into structural things for each department. We are very different, obviously. And I have no financial disclosure. We will try to go over some subtleties in gynecologic pathology and how is gynecologic pathology different from any other branch of pathology. Try to navigate some of the pitfalls. And as I said, the bulk of this presentation is real-life reports. I will show you real cases, and I will let you comment in your head about seriously. And we can talk about some strategies to boost patient safety. So the challenges in the landscape in gynecologic pathology were, first of all, gynecologic pathology has multiple organs. Each organ has multiple tissues. They come from different embryologic backgrounds. And we are dealing with gynecologists who are a very heterogeneous group of physicians, general gynecologists and gynecologic oncologists. These are two different beasts, and I will hopefully show you this. Nothing what I said now is new to you. Like you can say, well, how is that different from lung, or how is that different from GI? All systems are like that. Not quite, because in gynecologic pathology, the gynecologic oncologists are following FIGO staging, which is slightly different from the TNM system that we are used to. Imaging support in gynecologic pathology is literally zero, non-existent. So when you reflect on some organs, other organs like lung, for example, a lung pathologist relies so much on imaging. Imaging helps a lot in pathology, but imaging helps us very little in gynecologic pathology. Well, pelvic mass, duh, yeah, I know it's a pelvic mass. Serum biomarkers. Are you serious? What is serum biomarkers in gynecologic pathology? Really almost non-existent. Again, you rely on that a lot in other systems. And treatment is evolving in gynecology so fast. So these are some of the challenges common to other systems, and some are unique to gynecologic pathology. I like to start with just this one example of an email I received from a gynecologist saying, "Hi, Dr. Khalifa, I see the pathology report shows a Brenner tumor." What is that? You gave me no details on this. They are complaining about my report, not informative, just because I said Brenner tumor. And when you read that email, you immediately realize that you are dealing with a very strange provider, very strange gynecologist who doesn't know what Brenner tumor is. Is it benign? Is it malignant? And what more information do you want about a Brenner tumor? But the surprising thing about this email is that they didn't Google. Seriously, you can Google, just type Brenner tumor and see what Google is going to tell you. So I am reminded of our evolution over the years when we used to look at histology, and that's all what we had, H&E. Then we evolved into histochemistry, electron microscopy. I remember when I was in medical school, they talked about electron microscopy, like this was something coming. Immunofluorescence, immunohistochemistry, flow cytometry, and the list goes on and on. So now we are talking about spatial proteomics. So that evolution is happening, and it is moving our role, because before we were just diagnostician. Now we are providing information about prognosis, we are providing information about treatment, and we are actually driving innovation, as I will show you today. So I just want to bring that two-dimension in our heads when we use technology, and that changes our role. And that is the bottom line. We need to be more aware of the fact that taking more active role in patients' management increases our medico-legal liability and risk. This is the bottom line. Now, they rely so much on your report to treat their patients. And with targeted therapy, now it is what works with this patient is not going to work with the other patient, depending on keywords in your report. Let us look at this case here. This is an endometrial biopsy from a 63-year-old, whatever. So you look at that, I think we all in the room will say, yeah, that looks like maybe an adenocarcinoma. If you have time to get high power, you look at that, you say, okay, nuclear grade, maybe slightly high, maybe it's papillary. Could it be serous carcinoma? Is it endometrioid? Is it serous? Or what do you think? You want to, of course, you want to do P53, of course. So here is P53. It is strong and diffuse. So probably the diagnosis should be serous carcinoma. And what you do after that is you do HER2, and then you report that in your case. So this is not a challenging case. This is a case that comes at your microscope probably every week or every other week. Straightforward. Okay, so back in 2004, 2 decades ago, on the left, what happened if you just called that FIGO1 endometrial cancer? Well, the patient is going to get a hysterectomy with lymph nodes here in this country. And if it was limited to the endometrium, just observe. If it is deep, they can maybe give her some chemo or something like that. That is a wrong diagnosis. The correct diagnosis is to call it serous carcinoma. But if you called it serous carcinoma 20 years ago, they will still have done hysterectomy, maybe omentectomy, but again, observe and really not much. So that error 20 years ago would really had so little impact on patient care. That is my point. 20 years ago, to call it serous or to call it endometrioid really didn't impact the patient that much. Fast forward to date, if you called it FIGO1, of course you will do MMR, and as a result, again, maybe they will just do the hysterectomy, and if it is MMR deficient, maybe she can get some immune therapy. But that's about it. And that would be wrong. The correct diagnosis is serous carcinoma. If you call the serous carcinoma, that patient is going to have intensive imaging. She will have HER2 determined, and depending on this, she is going to get targeted therapy. Maybe she will get anti-HER2 treatment and will get immune therapy and chemotherapy. So the difference between management today is huge. That is why an error 20 years ago is different from the same error 10 years ago is different from the error today. So gynecologic oncology management protocols that I'm referring to, which is the practice of a gynecologic oncologist, they are very well defined. They are extremely well defined. And I haven't done other systems for a long time, so I really don't know how well defined treatment protocols are in other systems. I imagine they are also well defined. But in gynecologic pathology, they are really, really very well defined. And it's like splitting hair. They rely heavily on specific keywords, as I said in your pathology report, because they are less dependent on imaging. So your pathology report is virtually everything that patient has to go through her journey in gynecologic oncology. And gynecologic oncology protocols have evolved a lot in recent years. So in gynecologic pathology, these are some of the examples I just pulled out of my head where I think there has been a lot of evolution in the past couple of years. The molecular profiling of endometrial cancer, where did that come from? Like 10 years ago, probably, that was something you just hear about. HER2 role in serous carcinoma, this is very new. PD-L1 in vulvar and cervical cancer, this is also new, but it is almost now reflex test with every case. Recognition of P53 pathway in well-differentiated squamous cell carcinoma of the vulva. This is not new. This is about maybe 20 years ago. But until this day, I will show you some examples where pathologists are having difficulty understanding P53 in vulvar cancer. Genomics of ovarian cancer. Every case of ovarian cancer from our institution is sent for genomics. And they just snuck out the 2023 staging of endometrial cancer that it just happened last August, and we are, until this day, we are still trying to figure it out. I am lucky I have Liberty here with me who keeps me straight with every case, but I mean, like, really, it is struggling. Classification of endocervical adenocarcinoma, that's again less than 5 years old. HPV associated and HPV independent. So these are just 7 examples of where pathology evolved so much in gynecologic pathology in recent years. So through my practice, I identified certain areas that I think there are specific deficiencies in practice in academics and community. The molecular profiling of endometrial cancer is still a problem. I am fortunate to visit several departments across the country, and I meet with them, and I always take that as my litmus test. I ask them, how are you dealing with molecular profiling? And to my surprise, in many, many places, last week I was just at the University of Virginia in Charlottesville, and when I asked that question, they said, yeah, well, we do it, and the resident will fill a form and whatever. Like, it is so haphazard. Well, we are lucky that here we have a well-defined reflex testing policy, and it is done systematically, or at least we hope it is done systematically with every case. The concept of differentiated VIN, I mentioned the P53 pathway. The new classification of cervical adenocarcinoma, I still see that people are not really very ready for that. And clinically actionable diagnosis, and that is, I hope one day when I retire, people will remember me with this. If you want to remember me with one thing, it will be this line, that stop putting reports that you think are protective enough of you. And as I said, I am part of the problem. I have a big ego and I don't like to be wrong, so I use words in my reports that nobody can say I am wrong, I'm not really wrong. Yeah, but they are not clinically actionable. They don't help the gynecologic oncologist. And they get so irritated by that. They get so irritated when the pathologists use words that protects them, but not necessarily help the patient. I hope that my legacy would be about. All right, so here are some themes I'm pulling out from my practice. How really different can gynecologic pathology be from any other field? Like, if I am a general pathologist in the community and cases are coming, I do bone marrow, I do smears, I do cytology, I do hernia sac, I do endometrial cancer. Like, come on, how different gynae can be from anything else? I will show you this report. Can you read my report? All right. So this is an actual report from a galaxy far, far away. The endometrial curettage shows high-grade malignant neoplasm consistent with carcinosarcoma with heterologous elements. Perfect report, right? Nothing is wrong with that report. But then clinical correlation and follow-up are needed. What is this? Like, why did you say that? Like, and recommended. I wish Delhi was here. I told Delhi, don't go away, because my talk is all about recommended, that pathologists love this word. They keep putting it in their report. So you already called it carcinosarcoma, and now you want to come back and say clinical follow-up is recommended. Seriously. All right, so this report here, again, high-grade endometrial neoplasm, this one, it's an ovary, adult granulosa cell tumor. Perfect, adult granulosa cell tumor. But it just couldn't let that one go. Completeness of excision, and the margin is I can't, like, seriously. Again, if you know anything about gynecology and if you know anatomy, you know that the ovary doesn't really have a surgical margin. So there is no such a thing as completeness of report. So when gynecologists read these reports, they really get very confused. Like, what is really going on here? Another example of follow-up is recommended. Endometrial biopsy, crowded glands, extensive breakdown, consistent with at least complex hyperplasia. So they think that this is atypical hyperplasia and maybe cancer, I don't know. But then they cannot entirely rule out cancer, and then follow-up is recommended. So this is, again, of someone who doesn't really understand the difference between saying hyperplasia and adenocarcinoma, because the gynecologist need to counsel the patient and push her to the right decision for her management. And not every patient is going to be ready for a hysterectomy. Not every patient is eligible for hysterectomy. Maybe there are other morbidity. So it makes a big difference if it is atypical hyperplasia that can potentially be treated by hormones, or is it adenocarcinoma that needs a hysterectomy? All right, this is, I still see this a lot. Here is an endometrial biopsy, endometrial adenocarcinoma. I really don't know exactly what kind of adenocarcinoma it is, but I probably will determine based on the resection specimen. I already said that not every patient with cancer is going to go to hysterectomy. So again, here, the pathologist really doesn't understand that you may or may not get the hysterectomy. And of course, the hysterectomy could be done in a different place. This is one of the most common errors I personally see. So look at the diagnosis down in the lower part of the report where it says high-grade endometrioid adenocarcinoma. So this is a good report, high-grade adenocarcinoma, endometrioid. But then they do the markers and they do P53, and then they decide that it is a serous carcinoma. And many pathologists, if you show that to many pathologists, will say, so what's wrong with that? I already said high grade. No, it's a big deal to say endometrioid versus serous. These are two different tumors, different pathways, different molecular background, different treatment. So again, contradicting oneself in the report is something that we do to ourselves. All right, the next category is, I am just not familiar with these entities and I don't know their significance. Like, what's the big deal? I really don't know. And this is a case that I see this case maybe once every 2 years or once every 3 years. And the outcome of these cases is really, really bad. Let's say 57-year-old with abnormal pap, colposcopy shows a small nodule in the upper vagina. And this is a biopsy. So you look at that, if you are not a gynecologic pathologist, and you know that, well, we know H-cell. Okay, we got H-cell. In order to call something invasive carcinoma, I need invasion in the stroma. Yes, you do, except here. Because here, if it is a papillary squamous cell carcinoma, we call it papillary squamous cell carcinoma without invasion, This is a piece of information that only gynecologic pathologists know, and I took this opportunity to just share it with everyone, because what happens here is the pathologist will look at that slide and say, yeah, it looks like H-cell, and of course, the famous statement they put in the report, invasion cannot be ruled out. I don't know what that means. But as I always say, if the colposcopist tells you that there is a nodule in the upper vagina, and if it looks papillary, it is a squamous cell carcinoma. You don't need stromal invasion to call it carcinoma. And this is one of the very, very rare examples of this. So we used to call this papillary squamous cell carcinoma. The new WHO classification removed the word papillary, so it is just squamous cell carcinoma, papillary type, HPV associated. And this is the most common. I see this maybe every couple of months, a 72-year-old with vulvar itching. You can see here that there is the hypocellular zone, subepithelial, and then you can see a band of inflammatory cells. If you get high power, you can see the atypia and prominence of the basal layer, some atypical nuclei here, and probably you can see also a mitotic figure, 1 or 2. Look at the prominent basal layer here. So I think, and some individual cell characterization, some parakeratosis. So I think you can make a simple diagnosis here of lichen sclerosis and differentiated VIN. Differentiated VIN is still one of the most missed diagnoses, and I see. And look at this. So here, this is from an actual report that I received. P16. Of course, the pathologists thought that they do P16. And for the residents who work with me, they know how I feel about P16. I think it is really a very, very bad stain, and people are misinterpreting P16. So just because it came back P16 negative, that ruled out dysplasia. Of course it didn't, because this is the differentiated VIN that is not HPV associated. In differentiated VIN, this is the P53 pathway, and you will see positive staining in the basal layer as well as the parabasal cells. Do we have to do P53 on every case? No, we don't, because the morphology, I think morphology here is key. And as we always say that there are two pathways to vulvar squamous cell carcinoma. There is the HPV infection, and there is the chronic irritation by lichen sclerosus. HPV takes the P16 pathway, and that results into the classic VIN. The chronic irritation by lichen sclerosus will eventually take the P53 pathway, and we call that differentiated VIN. We call it differentiated VIN because the atypia is in the basal layer, but the surface is not necessarily atypical. They both progress to invasive squamous cell carcinoma. In the HPV associated, it is basaloid, and in the P53 pathway, it is well differentiated, and you can see the slide is always pale because it has less chromatin. So again, this is one of the common pitfalls of vulvar pathology. The pathologist does not think about P53, and they just want to see P16 positivity. The other category is, since I'm not really sure, I will cleverly cover myself, just in case I'm wrong. And I see that in many reports, and one day when I have time, I want to give a lecture about psychology of pathologists, because we are so averse to risk, and we just hate to be wrong at any expense. And I will use vague words so no one can say I am wrong. So here's an example. A 46-year-old female with a 14-centimeter pelvic mass. And here's the pelvic mass. Here's the cut surface, shows hemorrhage and necrosis. And I gave you just one slide just to give you the gist of the case. So how do you want to report this? If this is your frozen section, how do you want to report this? I think I will report this by understanding how the gynecologist is going to react to my diagnosis. And many times in frozen section, I actually ask that question. What would you do if I call it this? What would you do if I call it that? There's nothing wrong with that. So what the pathologist decided to do is to call it undifferentiated neoplasm, deferred to permanent. Let us try to decipher this. What was the translation here? What was the pathologist trying to say here? The pathologist was actually trying to say, I really don't know what this is. Let us wait for the permanent. That's what the pathologist really said. But this is what the gynecologist heard. This is a high-grade carcinoma. Let us proceed with lymph node dissection and staging. Well, because you called it high-grade neoplasm, like this is what the surgeon, what the gynecologist heard. Permanent sections showed this. Based on the diagnosis of undifferentiated neoplasm, the gynecologist proceeded with staging with lymph nodes. Permanent sections showed what could be easily detected as diagnosed as granulosa cell tumor. So is that a big deal? That is a very big deal, because if I know how the gynecologist is going to react to an intraoperative diagnosis of granulosa cell tumor, I would have thought twice about calling that just undifferentiated neoplasm and move on. One of my favorite examples here of vague terms, I don't know if you can read this, but here's the slide. This is an actual case, and I took a picture of that case of a uterine tumor that looks like this. If you look at this picture, don't read the report now, but just look at the picture. What would you think this could be? The differential diagnosis here is maybe cellular leiomyoma or maybe endometrial stromal sarcoma, or what is the classification of endometrial stromal tumors? Like there is the endometrial stromal nodule and endometrial stromal sarcoma, and the sarcoma is a low grade and high grade. We are familiar with that. So maybe we are somewhere here. So the pathologist chose to finalize the report as low-grade endometrial stromal tumor. What did the pathologist mean by that? Low-grade endometrial stromal tumor. If you read the clinical note at the bottom, the gynecologist said stage 1A low-grade endometrial stromal sarcoma. And in the history, she wrote down that this is a patient with low-grade endometrial stromal sarcoma. And then she asked me to review the case. So, and I tried to communicate with her, and then she thanks me for the review, and she says that I admit that I was confused, and I Googled endometrial stromal tumor, and that defaulted to endometrial stromal sarcoma. You see how the confusion happened? Well, to the pathologist's defense, the pathologist never used the word sarcoma, really. Well, this was not a sarcoma. So the pathologist never used the term sarcoma, and for that, the pathologist can say, well, I didn't do anything wrong. I'm not wrong. Yes, you are not wrong, but you confused the gynecologist. One of the famous games we like to play in our report is just to hide the diagnosis somewhere in the comment. Again, I wish Dr. Adey was here because this is exactly what he was talking about. So in the diagnosis line, the pathologist puts down complex atypical hyperplasia, blah, blah, blah. And of course, they couldn't help themselves, so they had to say uterine resection margin negative for endometrial hyperplasia or neoplasia. Again, that line can never be given by someone who knows anatomy. Like how can you say uterine resection margin is negative for endometrial hyperplasia or neoplasia? That doesn't make any sense. But anyway, so the bottom line here is atypical hyperplasia. But then in a comment, they put down that the focus of extremely whatever endometrial adenocarcinoma is there in the uterus. So we get this case. Could you please tell me, is this carcinoma or atypical hyperplasia? Again, hiding the diagnosis, your bottom line diagnosis in the comment does not help anyone. And sometimes you just can't win. Sometimes you just admit it's a losing battle. So here, one of my dear colleagues in the room had this frozen section and called it high-grade carcinoma with squamous differentiation. That was an ovarian tumor. But unfortunately, when you read the operative note, they say it came back as serous carcinoma. Actually, the pathologist never said serous. More clear, the pathologist cannot be. But yet, still, so yeah, sometimes we just can't win. And then there is the group of errors that I call, I'm just tired. I'm just tired. I'm done. Like, look at this report here. What's wrong with this report? This is an actual pathology report of a case. The pathologist didn't put a diagnosis for specimen A. So where was that? Like, how can I release? And I wish our EPIC beaker has a mechanism to block us from, this was not EPIC beaker, this is before this is a very old case. But still, some pathologists may release a report without a diagnosis. And this is, of course, one of the most confusing things when the pathologist was so tired, so they had to come up with their own entity. So this is an endometrioid. Look at the diagnosis, endometrioid carcinoma of the ovary, resembling 6-cord stromal tumor, FIGO stage grade 3. Like this is not a diagnosis from the WHO classification. There is no such a thing as with 6-cord stromal tumor. But you can see that the pathologist is tired and they are just throwing in everything. Maybe something will stick. The discussion will not be complete without one of my own errors. And this is a case from our own file, my own case, a 42-year-old with 15-centimeter pelvic mass. Here's the pelvic mass. Here's the cut surface. Looks necrotic, looks fleshy, white. Okay, do the frozen section. Okay, I'm tired. I'm looking at this. It looks benign. It looks like thecoma. Maybe it just looks like fibroma, really. There's nothing to write home about here. This is just a simple benign case, and we just released the frozen section as such. Well, not that easy, because on permanent sections, again, it was so cellular with many cells, and of course, my partner here had to do cytokeratin and show that this was a missed case of metastatic signet ring carcinoma. So how easy it is to make that mistake? Well, guess what? Krukenberg described this tumor in 1896. And here we are still debating about this, and we are still making mistakes about Krukenberg. So how many people in the room missed metastatic signet ring carcinoma on malignant on frozen section? I am the first to raise my hand. I missed it in the ovary, I missed it in lymph nodes, I missed it in omentum. Signet ring carcinoma is a notorious place for mistakes. So my last case here, which is a little bit long case, so maybe we don't have time for it, but this is another mental state that I see many pathologists do. They say, I'm going to give a safe diagnosis. I really don't know what this is, but you know what? If I give a safe diagnosis, it's okay, because nothing bad is going to happen to the patient. It's not perfect, but it's okay. So what happened here in this case, it was a patient with abnormal pap that was reported AGAS. They did a biopsy, and the pathology looked at it, and they didn't know what that was. Colposcopy said there was an abnormal area, so they called it, well, they just called it vein. It was a vaginal biopsy. Well, vein 1, how bad can that be? Like, nothing's going to happen to a patient when you tell her vein 1. Well, actually, that turned south very fast, because what they did was they cauterized that area. Because it's vein 1, they got a vein 1, so they cauterized it. And the patient went away and then came back with bleeding. And then when they did a biopsy, cervical biopsy, the whole tissue was cauterized. And the pathologist 2, couldn't make a diagnosis of adenocarcinoma. So the pathologist 2 also called it cauterized cells and let her go away. And now the patient comes back with real cervical cancer, adenocarcinoma. So I think you kept hearing the same message as Dr. Adey talked about before. If the case doesn't make sense, if the case is not fitting well, don't let it go, and don't just give something to get it out of your desk. The case needed more investigation. The details of the case is in the handout. I'm running out of time here. But what we need to be done here, I collected my 4 pieces here together. We need to familiarize ourselves with the subtleties of gynecologic pathology. Every system, gynecologic pathology is not unique. Breast pathology is unique in its own way. GI is unique, and so on. So if I'm going to work in a system, I need to familiarize myself with the subtleties of that system. Be comfortable with what you don't know. And that is, I think that is the first step on redemption. I am only human, and don't expect so much from me, because there is so much I don't know. And I'm going to ask. There's nothing wrong with that. How many times Dr. Klein gets me in her office and she looks at me with that look like, why are you here now? But because I need your help. I need hand holding. Is it squamous cell carcinoma or not? And for gynecologic pathology, particularly, study the locally implemented gynecologic oncology protocols, because they are not standard across the system, and every system has its own philosophy in gynecologic oncology treatment. And I hopefully now raised awareness of some of the pitfalls that I mentioned. So in closing, it is becoming a very highly specialized service, especially if you have gynecologic oncologists in your hospital. It drastically evolved over the past decades, particularly in specific concepts and specific areas with new therapies. And we need to increase our active role in patients' management. But while we do that, be aware that this is increasing your medico-legal risk, because now you are actually a partner in management. So thank you.
Thank you, Dr. Khalifa. I was actually laughing inside myself, you know, when I heard you talking about ego. And you know, I have to say that I never actually met a surgical pathologist without a strong ego. But I've met quite a few who know to hide it very well. And we get along very well because of that. So any questions for Dr. Khalifa, please? No questions? Yes, Kristen.
Okay, so you touched on DVIN, which is a big thing in our group, and just lots of discussion amongst us about what is that and what do we do. So I'm just curious, how often do you think you use a P53 to help you?
No, it's honestly, it's usually only, it's diagnostic when the histology is diagnostic, right? If you have a borderline case histologically, it's going to be borderline by P53 as well. So I don't find it super helpful. And he's a morphologist, so he makes the call morphologically.
Well, I also have to say that there are kind of, it's really a spectrum. It's not dichotomous, it's not black and white. We have cases, and I stand for the residence cases, where you have, and I always say there's nothing wrong with a patient with DVIN to also have HPV and also to have regular dysplasia. So we have cases with mixed, both of them are mixed. I'm still haunted by a case happened right before COVID of a 34-year-old, a biopsy that looked very much like DVIN. And I am guilty. I'm the extreme opposite of my partner here, Dr. Klein. She digs deep in patients' chart. I am guilty of not doing that enough. So it was a case that looked like DVIN. It's a DVIN, and I just called it DVIN. And I immediately got a phone call, and the gynecologist called me. She said, "Are you nuts? Like this is 34-year-old. Like how can a 34-year-old have DVIN?" I said, "Well, okay, let me look at it again." Looked at it again. Well, if it looks like a duck and quacks like a duck, it is a duck. So I called her. I said, "No, this is lichen sclerosus and DVIN, and I don't care how old the patient is." She said, "That's fine." And then she followed her up, and she did more biopsies, and she sent me another biopsy, and I called it regular VIN3, and she called me back. She said, "What's wrong with you? 2 months ago you called it this, and now," and I said, "I don't know." So I actually still have this case, and maybe I should present that case, because she kept biopsying her, and it's almost every time she plays a game on us, like she comes up with, she looks different. And I really don't know. I am really very confused. And there is nothing wrong with telling the gynecologist that this case has mixed overlapping features and whatnot. But what is not acceptable is to say it is P16 negative, then it is not dysplasia. That is not acceptable, in my mind.
Thank you, Dr. Khalifa.